Hello again and welcome to the latest edition of the Simply Endo podcast. Thank you for joining us again. As always, I'm here with Dr. Rob Masters and we're looking forward to this great chat this evening with Dr. Shalini Kanagasingam. It's a chat we've been waiting to have for a little while. Shalini's a great friend of ours and of Simply Endo, and we're excited to hear what she's got to say about all things endodontics.
So Shalini is on the Specialist Register for Endodontics. She completed her specialist training at Guy's Hospital back in 2009. She teaches undergraduate and postgraduate students in UCLAN. She's the course leader for the part-time MSc Endodontology programme and full-time MCLIN Dent Endodontology programme. She also accepts private referrals for endodontic treatment and also at the UCLAN Dental Clinic.
Hi Shalini, good to see you. Thank you for taking the time to join us tonight on a Sunday night, which has been a warm day. How are you doing? Okay?
Yeah, I'm good, thank you. Hi Dave and Rob. Thank you for the opportunity. I think it's going to be a fun chat. Well, at least that was what was promised. So, you know.
Yeah, that was the promise. That was what we falsely lured you into this, didn't we? Yeah.
It's too late now. I'm here, so it's going to happen, right?
Yeah. No, we're looking forward to having this chat. And I'm laughing because if you see Rob disappear, it's because he's having trouble with this chair sat next to me. He just keeps flying backwards and forwards. No, we've been meaning to chat for a while, haven't we? We know you've been busy, so we do appreciate you taking the time out to chat with us and stuff.
Pleasure.
Obviously, we'll get straight on with it if you're all right with that. Lots of people, I'm sure, know you and they see you, and you have quite an active sort of presence in the endodontic world and through social media and bits and bobs, which is fantastic. But for us, if we go back to the start and see sort of where did it all start for you really? What's your background that led to dentistry, and where did you do your dental degree?
Yeah, so originally I'm Malaysian, so most people, if you hear my accent, I think you can tell it's a very typical Malaysian / Singaporean accent. So I did my dentistry in Kuala Lumpur, so University of Malaya. I graduated 2003, and I started off. So at the time, compulsory service was just implemented. So any dental graduate had to serve 3 years with the Ministry of Health. And for me, that really did actually start my journey onto endo, because I think otherwise I would have happily gone into general practice and maybe, enjoyed private practice as such. But I was sent to Borneo. So I don't know if you're familiar. Kota Kinabalu. Are you familiar with, I can tell you a bit more if you like.
Yeah, please do.
Yeah, so so Malaysia's, you have the peninsula and then you have Borneo. Half of it is shared with Indonesia. So Sabah is the state that I went to. And at the time, when I graduated, there weren't enough dentists, and certainly not enough dentists in sort of more rural areas. So I had, it was really a good experience going there and just, your first year in dentistry, I'm sure you guys were the same. Graduating from dental school, you are in no way ready for practice.
Literally, yeah. It's quite frightening, actually. When you look back, it is actually quite frightening, isn't it?
And I think, it's quite important for us to kind of say that to the younger generation as well, because people coming out now, they're nervous. Some of them not very sure of themselves, especially, things like endo. And I probably, surgical procedures and stuff like that, oral surgery, probably not the most confident doing procedures like that. And I feel like, them knowing that even sort of our generation, I'm assuming we're all similar-ish in terms of when we graduated. I'm going to assume.
Yeah, I was 2004.
You can jump in and tell me if I'm wrong.
No, 2000.
There you go.
2004.
So, yeah. Right. So, yeah. So, and I think not making them feel like, oh, we knew so much more. We did so many more endos and extractions than you guys. I did 11 extractions in dental school. And a lot of these were perio involved as well. So it was kind of like, I was actually thrown in the deep end because, again, in Borneo, we were doing extractions on a daily basis. People would come by the busloads to Kota Kinabalu, which was the major city, with toothache, and all they wanted was the tooth taken out. And I learned very quickly that I had to build up the skills to extract teeth, and also not to dig dig at upper teeth, when you've broken a root, don't cause an oroenteral fistula. The oral surgeon said just leave it, But then I also sort of felt I didn't do dentistry to do extractions, even though I was kind of getting better at it because it was a daily occurrence. And I thought, what about saving teeth, and that's when sort of endo came up, and they actually allowed me in that sort of dental clinic to start to do some endo. And I only started with sort of more anterior teeth because, technically we had to justify what, the case selection. So we started, just to say like we give patients the option for anterior teeth at least to save them. So yeah, that's kind of, started, my endo journey, just thinking of saving teeth rather than taking them out.
And how much endo experience did you get as an undergrad?
So I did a couple of endomolars. I had an amazing supervisor. So I don't know if I can just shout out to him, So Dr. Tan Boon Teck, who was trained by Prof. Harold Messer at in Melbourne uni, and he was just so encouraging. Every step of the way you'd show him, and he would have something really positive to say to you, to say, "Oh, well done," and he would say it really loudly so that everybody else could hear as well. Mm-hmm. And he treated everyone, like that. He was really encouraging. So it almost made me feel like I wasn't afraid of doing endo, and it made it a very pleasant experience. Yeah, it does make a difference, doesn't it, when you have teachers like that? And I'm not saying, I was obviously doing everything perfectly. Yeah. So, I don't know if you guys had people at undergrad level who inspired you as well to do endo.
Yeah, definitely. Did you?
I had plenty of people try and uninspire me, but which is where I suppose my passion for teaching has come from. But certainly there was definitely a couple of people there that were dental school would have been very painful without.
Mm-hmm. So I think it works both ways, because I had that experience with maybe dentures. Till today, I am not. I'm not a fan, or I don't feel like I do them very well. I don't make very good dentures. I probably need to go back and retrain for that. But again, that's it does impact you. I think like if like when you have good teachers, yeah. And I just want to say as well to both of you, I've met a lot of colleagues at UCLAN who teach our undergrads, and just going to British Endo Society meetings and such. I meet a lot of your students. And they've got a lot of good things to say about how you've run your program, how you encourage, how you teach, how you mentor. And that's the basis of just creating more dentists with special interest, or at least just, general dentists who want to do endo and are brave enough to do it. So it's a good thing. It's a big thing as well to have that.
Yeah.
So, yeah.
It's very kind.
It's nice of them, isn't it?
Yeah.
Yeah.
Those bribes are working out.
Those envelopes.
I try that too. No, I do that with food whenever I can. But yeah. And I think, what? People pass it on. So some of the things you've taught them, I see them speaking to my undergrads. When we're in Phantom Head, we're all together. And you pick up things, right? You pick up how other people teach. I'm always fascinated with how a concept or something, how someone explains something. And it's really an art, isn't it, to teach when you try and simplify things, not make things more complex than they need to be. So and I think with Simply Endo as well, I feel like for your team, you are making endo very accessible to everyone. I think I can say our prosthodontist who works with us has also taken up basically your alumni. They've done the 10-day course with you, so. I mean, good on you, good on sort of Mike Parks for establishing this, and then obviously you guys are taking it forward. It's about giving everybody that opportunity and to kind of have that little bit of extra training post-graduation, because there's no time in undergrad really is there to try and give students everything. We try our best, but they do come out, knowing there are some gaps in their knowledge and skills. So, yeah.
Yeah.
That's one of my big bugbears is when people are, I get cross when people, are slag off basically, the newly qualified dentists. It just it drives me nuts, because we should be there to nurture and hug them and get them through it rather than bat them down.
Yeah, and not to scare them.
I remember them saying about us. Yeah. Definitely.
I do find it funny though. You know, you're saying about people learning certain concepts that we do, but I do find it funny sometimes. Sometimes I bump into people and they'll tell me things that I've told them.
Yeah.
But they'll explain it back to me like they're teaching me.
Yeah.
And they'll describe something and I'll think, I'm sure that's what I've taught you, but they'll tell me. And I have to then pretend that I'm learning it for the first time. But yeah.
Isn't that the ultimate sort of compliment, though, Dave, right? So you've explained it to them well enough. They can now explain it back to you. They've just forgotten that, obviously you taught them in the first place.
It's the lack of credit that gets me down then, though, isn't it? The lack of, acknowledgement.
Acknowledgement, citations are important. Yeah, that's true.
Yeah.
So, yeah. So, I mean, just to wrap up.
Then?
Sorry, go ahead. Sorry.
How did you come across to the UK?
Yeah, so while I was doing my compulsory service, in my second year, some of my seniors were saying, look, we need to sit MFDS Part A if we're going to, even attempt to get a scholarship to do postgraduate training. So I just kind of got swept along because I had a few friends who were sitting the MFDS. And again, that's something I encourage all my students to do as well, post-graduation. And that kind of opened up doors for me, basically. So then I joined university. So as soon as I finished my 3 years, I joined academia. And then I was lucky enough to actually get a scholarship to go to pursue my MCLIN in endodontology. And I did that at King's. Guys, basically.
Oh, wow.
Yeah. And again, well, I don't know if it's controversial of me to say, but I think this is quite well known. There were two schools at the time that you could apply to do endo. I think now there are way more, obviously, universities doing it. We do it at UCLAN as well, specialty training and sort of part-time MSCs. But I think the philosophies were quite different for what you got at Guy's and the other institute. Again, I felt very much supported there. I was not used to first name basis. So calling Francesco at the time was very difficult for me as an Asian. You wanted to call him, Dr. Manocci. Of course, now he's professor. But it was just like we were treated with as part of a team. I felt that way, post-grads. And I learned a lot from my seniors as well at the time. So I'm sure, Bhavin Buva, Omar, they were 1 year above me. And everybody kind of looked after each other over there. We were small groups at the time. So again, I was very lucky to get into a very nurturing environment. And I mean, that just makes your love for endo grow. And I had an amazing 3 years at Guy's doing my MCLIN there. Yeah. And then I had to go back to Kuala Lumpur, to the university that offered me the scholarship so that I could, if you had a scholarship for 3 years, you then work for another 6 years, which was fair enough to sort of almost like pay off the scholarship. And that brings us to 2016 when I started at UCLAN. So that's my life story there.
Wow.
Yeah.
Wow. And how did the UCLAN job come about then?
So I was approached by Professor Sinjan Queen. We had worked together. So again, in Malaysia, I think what opened doors for me there as well, I was very active with the Malaysian Dental Association. So I got to meet and speak to a lot of international speakers at the time. One of them was Sinjan. I had known him because I'd also done a MFDS prep course at the Royal College of England. And yeah, he said there was a job opening for course lead endo. Sorry?
Yeah,
he's Max Fax, isn't he?
He was high up though at UCLAN, wasn't he?
Yeah, I think at the time he was postgrad lead, and then eventually, I think by the time I started, he was the dean of both the School of Medicine and Dentistry. So I was very lucky to get that opportunity to come over. So, but then again, jumping in straight as course lead, there were some challenges as well. But being a small school, I think we don't have departments. Everybody's just, again, you just have to work with everyone, and you get to know the staff members very, very well. And I think it was, it was a nice environment as well for me to kind of build up, because I felt like I was starting from scratch in the UK, because like nobody would know me, and we were trying to promote the courses and such. So that was a bit of a challenging time trying to just kind of get to know. And also in the Northwest, I don't know, at the time I hadn't gotten to know you guys as well. It felt a little bit isolated being where I was and I was the only endodontist on campus. So yeah, I don't know what it was like for you. Did you start straight away as a team? Did you already have that established when you started teaching at Simply Endo?
No, I think it's a good question, that, isn't it? Mike had obviously set it up originally, and it was just Mike. And then I think as he realised that it was getting busier and more courses, and probably also it's sometimes nice to hear different points of view, isn't it? And I think one of our tutors who does a lot of our marking, Steve Cowling, he got involved early on as a tutor, along with a guy called David Blaine, who was a really good clinician from Leeds. So they both done the Simply Endo program, and then Simon Barnwell, so Simon.
Yeah.
He joined, I was probably similar time to Simon, I think about 10, 11 years ago. But as you well know, I was and I still remain the black sheep at Simply Endo, because I didn't do the Simply Endo program. So the thing that I have in common with at least you is that my connection to UCLAN, having done the UCLAN.
You were a UCLAN alumni.
Yeah, when it was
done very well for itself.
There you go. So when it was Sanj, so Sanj did the first program.
We
don't really like talking about.
No, Rob doesn't talk about it. So so I was roped in.
I'm glad we got that information out. So
When did you start, Rob? You started teaching?
Yeah, so I started just before we moved to Formby, so it'd be 2016, 2017.
A couple of years after. But yeah, in terms of a team, there was obviously a well-established team with Mike and the, Anita and Lorna, the back staff, if you like, wasn't there? And a course that was probably really established. We just kind of came in and just carried it moving forward, really, wasn't it? So, whereas I think, the UCLAN course that I did is very different to what you do now. I think, obviously, you've got the patient contact and stuff, which I didn't have. And,
right. So that's how it started. So you're giving me a bit of a history lesson here as well. So, I mean, obviously, big name to have Sanjeev Bandari sort of establish the course. I'm not sure who did it in between, but when I came, there was Mike Jones, who did a brilliant job as well, with the curriculum. He had also, I think, put his take onto it. So he was handing me over a good course. So again, for me to take care, but like you said, having those extra voices, having someone to kind of just to to talk to say what's the best way forward. So I was lucky after that actually to have Rose Thomas, who's one of our alumni as well. She was she graduated, I think, 2016 with a distinction, and we just kind of also lured her back to do some teaching, and she's teaching with me now as well. So lucky to have her sort of her input, and especially because she's a practice owner in practice as well. I think bringing that voice is into it. So I think it's quite difficult. It's quite different when you're based sort of hospital dentistry or university dentistry, and how things are done in practice. There are some nuances to it. Some things that can be more easily done, in a university setting versus being in practice. Because I only started practice sort of 3 or 4 years ago. Right. So I didn't start in the UK straight away, because I thought, I want to focus on my job, my academic job. I want to make sure I do that. And then I just realized, what, if I'm not in practice, just having at least a reminder of what my students are facing on a daily basis, then I feel a bit of a fraud. Because I can tell you to do, I think we're going to get into it at some point, vital pulp therapy. I think we were going to discuss that. And I also feel like, it's so different saying to patients, you're in the university, we're going to, subsidize. So we're not an NHS practice as such. So we do charge patients, but it's a highly subsidized fee. Versus when you are in the real world and you have to charge them and actually obviously make a living from that, make sure the practice gets paid, sufficiently as well. Those conversations are slightly different, I would say. I don't know if you feel the same. Yeah.
How did you find that then, dropping into practice quite late on? Then was that, is it smooth transition or a few hiccups along the way? Or?
So for me, again, when I was in Malaysia, I was doing my Saturdays in practice. And I worked for my mentor, like I told you, Dr. Tan, who was my teacher before. So again, and also I think that was quite important. So to graduate with, supposedly, specialist, right? 3 years full, I did the program, I'm coming out, people expect me to be, on the ball. But again, there's a learning curve. And I felt safe that I was working with a very experienced endodontist who guided me through that. So I was doing that sort of a day, sometimes a day and a half a week. And then obviously when I came here, it took me a while before I sort of went back into practice. So I actually I do enjoy it. I still do very much enjoy it. And again, in Preston, I don't know if you're aware, but there are not too many specialist endodontists. Quite a few dentists with special interest, some of whom have trained at UCLAN as well. So I thought I was at least, contributing in some small way, and yeah, I do enjoy it. But again, maybe we can go into it as well here to discuss your experiences. But those conversations, the costs, when things start adding up for patients, the root canal costs, the crown costs, and then I always make sure to try and, because my practice principal is an implantologist, that consent process, I make sure I include the cost of a single tooth implant as well for them to consider, or if it's multiple, just so they know what they're getting into and they know what the alternatives are. Whereas I suppose at university, it's very much easier to tell them we can go through different stages. And sometimes, if a primary treatment doesn't work, you go for a retreatment, you go for an apicectomy. The cost, because it's so subsidized, most patients don't find that as a barrier to deciding.
Was there a difference between working in Malaysia and working in the UK? Have you noticed any differences there?
To be fair, I think because I don't know if you're aware of how the education system works in Malaysia, because we're Commonwealth country. A lot of what we do is very much British in style. My lecturers at university were trained at the Eastman, for instance, and they were UK trained, so that the style of the way they taught and the principles were quite the same. So I think in practice as well. I felt it was pretty similar, although I will say the practice that I was in Malaysia was maybe a little bit more high-tech at the time, because the practice principal had invested in Morita chairs. I don't know if you've used Morita chairs where you've got the apex locator. I mean, this is the only thing that endodontists will get excited about. Ooh, I get to plug in my apex locator into the chair. And then he bought this chair because actually they had flown us to Japan to visit the Morita factory because he was going to buy like 5 chairs of them. So there was a chair where they placed us on it. And when you moved it, if you closed your eyes, you wouldn't feel it moving. And he had a Morita CBCT machine. We had multiple screens in the surgery. In every surgery was well equipped, so that communication with the patient was really easy. You could bring up your CBCT, you could show the microscope images, you could record. So yeah, I kind of missed a little bit about that, those facilities when I first came here. We have caught up now, obviously, but yeah. I know it's not to be expected because you'd have thought things were a bit better here. Also at university, like my periodontists at my university in Malaysia, they were into lasers. They had all the fancy equipment, and then coming to the UK, I mean, no offense, but it wasn't.
You've got a scaler and some floss.
Yeah, Again, it's funding, isn't it? At the end of the day, and it's where you want to put that funding. But yeah.
I had a Morita chair at the practice when I took over. It was a chair called a Morita Space Liner, and it was probably a bit old, really. But the handpieces were in the back of the chair
as well. Yeah.
But sometimes people, if they had long hair, it would all be wrapped in the handpiece, or and to click the high speed on, you had to sort of press it to click it on. Yeah. But you pressed it and got it wrong. The wire went down the back of the chair. So then you had to get the patient off the chair to take the back off, and it was just. But often you get technicians, the engineers would come in and they'd be astounded by it because no one had ever seen one. So it was a comfy chair, but it just wasn't practical for getting repairs and stuff. So we got rid of it fairly quickly. But Marita chair.
But I mean, what's your favorite? What's your favorite Apex locator? Are you still? Is it?
Marita obviously is the one, isn't it?
Marita, the one I use now actually is a Care one, the Care Elements Connect.
Yeah.
Which works really well, to be fair. Yeah.
I think it's ingrained in me, like the Roots ZX, right? But I feel like also now, like you said, there's so many more options on the market now that have...
Yeah, they've all caught up, haven't they?
Right?
Apex Pixie is nice, isn't it? And
I bought my Marita probably in 2010, and whilst several nurses have tried to break it, it's still going strong.
Yes, if they drop that, your heart sinks, right? But yeah, I would say, like, I think that's a good thing about endo nowadays, right? Like, even with microscopes. I mean, at the conference, I was looking at all these alternative, well, not really alternative, they've been around for a long time, some of these brands, Alteon, and I remember using an Alteon back in 2010, and what it looks like now, wow, it's comparable, so, and before this, we were just looking at Zeiss. I think at Guys, we only had Zeiss or Global. They are good brands, but then you've got Zoomax coming up, you've got CJ Optic. There's so much more options that are actually quite affordable for our colleagues to choose, to actually get all that equipment, compared to back in the day where it was, you had less options and it was, I suppose, more expensive. So yeah.
So just moving on slightly then, you've just finished or handed in your PhD, haven't you?
Yes.
So how on earth did you find the time for that, and how are you still sane?
Nobody said I was still sane, so I have a problem. I have a problem with saying no, in case you haven't noticed. So, like, when you asked Stephen to do this podcast, like I told you, I was a bit nervous. This is my first podcast. Obviously, I mean, I've spoken to you guys before. You've obviously calmed me down, but I would never have said no to you. Because I thought, it's so lovely to be asked. Why would I say no? And this is my principle for most things. So because of that, actually, the PhD took a backseat many times when it, if teaching or other CPD commitments. I don't know if you're aware, but we do a lot of. I organize a lot of CPD via the British Dental Association Northwestern branch. Over at UCLAN. So a lot of that did take up a lot of time. So I took quite a while to do the PhD. And my first topic was actually more endo. We were looking at disinfectants, and we were looking at nanotechnology, so nanoparticles to be used in disinfection. But a year of doing that, it wasn't really going anywhere, and I was lucky to get some funding from the Royal College of Surgeons, Glasgow, to pursue a different topic. So my PhD topic is actually around P. gingivalis and its links to Alzheimer's disease. So that was what we were doing. It's laboratory studies. Mine were basically based on laboratory studies, and there's no causal sort of relationship at the moment. It's but there's mounting evidence, as with a lot of systemic diseases, linking back to periodontal health. But I think even with endo, we're reading so much more now, with work from Sadia Niazi, for instance, cardiovascular disease, diabetes, and how that, has that bidirectional relationship with systemic health. So, so that was my PhD. And the Viva will be at the end of the month. I hope I can give you guys some good news, at that time.
Will. How does the Viva work?
So because I'm a staff member, so I have to have 2 external examiners and then 1 internal examiner. So I think we booked out half a day basically to have that defense of my thesis, which, to be fair, actually, I mean, if people are interested in everything I've done and written, it's quite a nice thing to sit down and talk about it, right? I'm going to psych myself up that way, But because we use pretty much every single laboratory technique under the sun, you have to, because my supervisor was quite enthusiastic about trying different techniques, so you have to deep dive into every single one, so you have to know everything. about everything.
Jeez.
So yeah.
So when our students moan about a 20-minute Viva, we can steer them in your direction, can't we? Half a day.
That's tough.
Half a day.
I suppose I imagine a PhD Viva normally would take about 3 hours, maybe a bit more if it's a particularly interesting one. But that's and I think again there's so many ways of getting a PhD now. You can get a PhD, you can get a doctorate in education. So if again us as academics, and we've taught for a long time, haven't we, amongst, you may want to actually go down an education route. You could look at how you've been teaching, with Simply Endo in terms of even how sort of the preclinical aspects, or, there's so many things you can dive into to get that way. You can do a PhD by publication. So you've done a couple of publications that are sort of linked in terms of a theme. Then you write a 10,000 word submission to then get it that way. You still have the Viva, right, but that's a nice way of doing that if you've already started to collect some publications. So again, with PhDs, I think there's more options nowadays compared to maybe, 20 years ago, where it was, you had to do it, sort of full-time or part-time.
Do you fancy that, Rob?
Not just at the moment, but
I'll ask you again next year. You might be inspired, So
it's funny, isn't it? Do you think? I mean, because you must then cross the boundary a little bit then between being quite a wet-fingered dentist and the academic dentist as well, isn't it? Because sometimes you don't get that. We were talking about dental school before, and people who inspired you at dental school and stuff, and some of the people we had at dental school, you wouldn't have let them do treatment on you, but they were telling us how to do it, but you wouldn't have let them do it because they weren't technically very good, but they were probably working in the dental hospital because they weren't very good, maybe. Not all of them, we had some great people, but that's difficult, isn't it, that academic? And
Rob's like, Dave better not name names over here. Yeah, you're going to get into trouble. No, but I know where you're coming from. And I guess it's also different when you've got somebody like, I don't want to say older, but more senior, and they've done their 30 years of practice, and then they've decided to, rather than people who are maybe coming in a bit too early and then giving up that clinical. And maybe I actually still enjoy my clinical because I've never actually done it 5 days a week. What about you guys? I mean, because of you have to kind of also manage your teaching, so if it's not every single day, I think you still keep a little bit of that excitement and you enjoy it a bit more because
both.
It's not the grind.
Isn't it? I suppose the clinical bit breaks up the teaching a bit and vice versa, doesn't it? I think you're doing one all the time.
It's a nice balance, right? I think we're pretty lucky, aren't we, as teachers, to have that balance to do a little bit of everything, and I do enjoy it.
It makes you believable as well, though, isn't it? If you're going into practice on the Thursday, Friday, and then you're going back into UCLAN on the Monday, and you're sharing cases that you've done, where you're saying, actually, I've done this and it worked, or I did this and it maybe didn't work.
And you know what? I make mistakes. We make mistakes, and I think sometimes you learn. Although we show up, I've seen your amazing cases on social media and stuff. They're beautiful, but also at the same time, I'm sure when you share that, like you said, when things didn't work, our students actually appreciate it when we're telling them, okay, like don't fall in that hole because I've done it, crawled out. I'm going to tell you now how not to do it.
Yeah, I think that's so much more powerful than pretty white lines on social media. I do think it's it just makes you believable, and it makes it real world, and people take it on, don't they?
You don't. But that's the point, isn't it? That's quite frightening because people won't on social media. People wouldn't share the bad ones, would they? You wouldn't.
I've seen a little bit of a change, though. Not everyone, obviously. And the thing is also, I think it's a danger there, isn't it? If you share too much, because who is your social media facing? I have spoken to some prominent influencers about this as well. If patients see it, they might take it the wrong way. Whereas if colleagues actually see you talking about maybe a small, something that didn't go as well, but, and things like that, we would appreciate it because it's a learning and it's about reflecting, right? So I guess it's a slippery slope, or it's maybe it's not as straightforward as coming back. But for those who are brave enough to show some of those cases that hadn't gone completely well, hats off to them. It just makes the rest of us feel more human, Because if you look at all this, everything's looking up, like you said, pretty white lines, and the access cavities are getting smaller. There's barely any dentine being removed these days, in the root canals, but they're still getting the lateral canals. And when that doesn't happen for you, right, it does. I don't know how it makes you feel. Like I have students coming up to me going, why am I not getting these results?
And I think that's the big thing. You go back to the, to the newly qualified. It just makes them, it's demoralising them because they think that's what everybody's doing day in, day out. And when they're not achieving that, and that's one of the big things I also try and talk about is it's not, you can only do what the tooth will give you ultimately, can't you? And don't think that people doing endo all the time are always getting pretty white lines, because they're not.
Yeah. And then sometimes when we get a little bit of a puff through a lateral canal, of course I feel happy. But I think then I've also heard, people at Rikuchi say, what does that actually mean? It just means subsealer has gone out that way. Does it mean you're going to get, is that going to guarantee you success? Not necessarily still. I mean, it's nice if it does occur. I probably would say it maybe happens for me a little bit more if I've done a warm technique versus, sort of single cone type situations. But I don't really know, like when you're asked, how do you get that? I can't really give you a straight answer, because sometimes it's after the fact that it's occurred, and I'm like, oh, that's a nice result. But I didn't really, I did everything the same way, right? I spend time irrigating. My nurse is, I've got 2 hypochlorite syringes going, she knows, I'm going to use up loads. We do all that, right? We activate. Do you guys have a preference for activation? Like, what's your go-to?
I do both, sonic and ultrasonic.
Yeah, I probably do sonic more. Although since the new endo activator came out from Dentsply and they show us what the old one did, I now realise it probably doesn't do a lot, does it? The new one's really good, but the old one maybe doesn't do as much.
It's quite a drastic change in terms of the amplitude or whatnot, and but it makes me feel good, right? Am I really doing that much? I don't know, because also, so when I was teaching at King's College Hospital, all they do over there is GP pumping. That's, okay. Yeah. And I'm sure I'm not going to get in trouble for this, but they were using Tubli-Seal as a sealer.
Yeah.
Good old Tubli-Seal.
Yeah.
I mean, they have other options there as well, but Tubli-Seal was well and alive, up until the last time I was there, So endo will work if you, obviously, biological rationale, biological principles and all that, right? But I do like the feeling that I know I'm doing something extra. I do like that I've done some activation. I spent, whatever is it. It's a bit random as well. People ask me, how long do you activate per canal? 30 seconds. Must have heard someone tell me that somewhere. I have no evidence for it, right? Yeah. And when using ultrasonics as well, you can see all that bubbling and all the, things that come out of the canal. It makes you feel good as well, right? But again, are there any actual studies that have showed significantly different outcomes if you ultrasonically activated or not? I know they tried to attempt one study previously, and the outcomes were similar, but it was short term, 1 year. Maybe it needed to be long term. But I think also a lot of the things that we do, sometimes the extra bits that we do, I feel like it comes from my own belief that I'm doing something good for my patient. So
I think it's the little wins, isn't it? I think once you start doing most things well, these extra, it's just these, you just want to get these extra couple of percent here and there, don't you? And if you start adding 2 or 3 of those all together, then that's what, to me, I think is what starts making the difference, isn't it? It's the little wins, really, with that. But ultimately, you want your basic biological principles to be there, don't you?
With that, Shalini, where do you sit on the fence with, or do you sit on the fence? Where do you sit in terms of minimally invasive endo? Everyone's going skinnier and skinnier, and these, you mentioned access cavities, but obviously that ties in a bit with our biological principles and activating the irrigant. But are people just going daft now, or?
I know it takes so much skill, and it's great when people do achieve it, and then it's all there on social media to show what a small. But I can't teach that. Can you? I mean, I like not conservative. Yes, try and obviously not remove excessive tooth structure. But how many times do you guys get like intact teeth? I don't. I'm struggling. You know what I need to learn more now? Like I'm looking forward to attending Krina Patel's lectures, deep marginal elevation, like trying to rebuild these compromised teeth. So to be honest, I don't teach those ultra conservative access cavities. I don't believe in them, and I don't think there's actually current evidence to say that they prolong the life of the tooth. But it makes sense not to over remove dentine, right? I mean, that's something that we can, but especially for undergrads, when I'm teaching undergrads as well, I mean, they're not using magnification. So I would rather they can see a little bit better, maybe like access cavity should be orifice sort of based, right? And it's a dynamic process. I tell them, okay, you've done the access, but if you need to remove a little bit more, just so you can actually get a file in without risking file fracture, and you can actually see better, I'm okay with that. Within reason, obviously. So, what do you guys think, and what's the expectations when you do your access cavity?
I like to moan and rant about it really a lot, because we looked back, didn't we, when we did an alumni day, and that was about minimally invasive endo. We look back at where these sort of things come from a little bit. The pericervical dentine, the Clark and Kadami paper, which people quote, but I don't think they've ever really read it. So we look back at that. Which is just a bit of a chit chat, isn't it? And then interestingly, in that the access cavity that they produce in that is kind of a standard nice access cavity. It's not something that's tiny. And then there was a systematic review done in 2021, and it basically said, where do these minimal invasive access cavities come from? And it said it was social media. And it's quite scary. I do think we've created a problem because we've got microscopes, and you've obviously said it about the undergrads not having the magnification. We can do stuff smaller, and because we can do it smaller, we make these small access cavities so then we can get in, but then maybe we need the tools for the smaller access cavity, and we've sort of gone about it. I think we've ended up almost a bit by accident. But our teaching is still very much thinking of the biology, isn't it?
Yeah, definitely. There's no point in a tiny access cavity and a rubbish endo, is there? Ultimately.
But what about the files? Like with the files, I feel like, so I'm very much I grew up ProTaper, and then ProTaper Universal, ProTaper Gold. So and we were taught, if you remember, in the beginning, to brush, right? And we create these flares, So that, I think, I have changed. And so currently, using ProTaper Ultimate, or even sort of like Wave 1 Gold, I think actually does still fit in with sort of those slightly slimmer shapes. I'm probably not brushing. I'm not trying to remove too much coronal sort of root sort of dentine. But again, I probably wouldn't want to go too small either, because I feel like I need my irrigant, to predictably go down. I mean, but I do see that trend as well, going that direction, but maybe not too extreme. So I feel like Ultimate, for instance, is a nice sort of middle ground. You're not getting that, what do they say? The maximum file diameter is less than 1 millimeter. So that's I think that's acceptable if that's a trend that we're going to adapt. You
also, I think, because of the Ultimate, you do still get that deep shape, don't you? So it is easier to irrigate apically better, isn't it? I'm very similar to you. I use Ultimate and Wave 1 Gold. They're kind of my go-tos.
So what about in terms of where do you stand? So root canal treatment versus vital pulp therapy. How much are you doing?
That's the most minimal endo you can do, isn't it? Do no endo.
I mean, that kind of segued right into that. So
we should swap places, shouldn't we?
I thought you planned it, so I was just going with the flow.
It's funny. I've dabbled with more of it over the last sort of 12 months or so, and certainly on sort of shorter term follow-ups of sort of 6 months, where I'm getting patients who are coming back in and they've got no symptoms, and they've got teeth that respond positively to cold and that sort of stuff. So I'm being a bit selective because of most of my stuff, obviously, like yourselves, will be referrals. Normally by the time they've got to me, someone's accessed it or they're necrotic. It's rare to get those ones where you're a bit on the fence with, is it reversible? Is it irreversible? Can you do something? I've learned something. I mean, Rob, you taught me lots of it when we were doing that alumni day, because we put a presentation together, didn't we?
Yeah.
Looking at protocols, and I think it's a nice idea. I'm just not sure how practical in sort of general practice it sort of is. I'm not sure.
It's also the worry. I mean, look, just what you were saying earlier, wasn't it, Shalini, about you know, I suppose the cost, the number of treatments. If it doesn't work, you've got to look the patient in the eye then, and you know. So I think that certainly plays a factor into it, doesn't it? And also, it's different. You know, I mean, when I was at dental school, if I'd have said, let's look at, you know, vital pulp therapy on irreversible pulpitis on you know, mature teeth, you'd have just got laughed out the clinic, wouldn't you? So so ingrained in us that it's not you know, it's that mind shift change, isn't it? Which is taking time, and the belief in it that it works. And I suppose in a hospital setting where the fees aren't, you know, a big concern, your reputation is always important, but you know, I suppose, you know, your business is driven by patients coming back and getting, you know, dentists having confidence in you. It makes it trickier then, doesn't it? You know, to do that.
What's your
experience? You guys said that, because I feel like I'm exactly where you are. So I am doing more now, but definitely it's been within the past year that I've started to feel braver to do it. And again, it's easier for me at the university to go, let's try this, you know, and if it doesn't work, we'll go for a root canal. Like, I mean, even things like charging, like I'm always curious to know how people charge for it. So sort of a happy medium that I found in practice is, okay, if I charge half my root canal fee, and I describe, you know, of course, we're going to go through consent. We're talking about all the risks, and you know, when patients may come back, you know, if the symptoms don't resolve, or actually, you may still need the root canal treatment. So if you do come back, then you pay the other half of the fee, and you get a root canal. You've got the root canal treatment done. But then also that means I'm kind of taking the hit as well, if you know, because then. You know, in a way, right? I mean, I hope the math is mathing there, but and again, there are not that many people who are coming back. But like you said, if I'm getting, you know, patients referred to me, I want the confidence from the referrers as well that I'll be solving the problem. Sometimes patients don't feel happy that they've come back to you, even if you told them that if it doesn't work, you know, if you do, you know, you've got a plan B. Sometimes they don't like that. It's the inconvenience of it as well, isn't it? So I do struggle a little bit with that, and that's what I do in practice. And again, we should be doing more, because we know that the evidence tells us it works. In fact, rather than do a direct pulp cap, where the evidence shows us that a pulpotomy, or indeed actually a full pulpotomy, has much higher success rates. So we should be. You know, I know we should be doing more of these types of cases, and we're not limited to irreversible pulpitis, because the evidence shows us it works in not reversible pulpitis cases, but even irreversible, right? And then sometimes I think, okay, I'm taking a PA and I don't see a lesion on that, and I've dubbed the tooth, I've diagnosed that as a case of irreversible pulpitis based on the symptoms, spontaneous pain, as such, but. Also, if I took a CBCT, then, you know, we know that, you know, the accuracy of CBCT detecting PA lesions, you might see a PA lesion there. And would that make you feel like going in a different direction? If there was a small PA lesion, would you then say, oh, you know what, this has got to be a full pulpectomy as such, I'm going to have to do a root canal treatment?
Yeah,
I don't know. I mean, yeah.
It was 2015. Was it the Tahoe study, which was basically looked at that, wasn't it? And that was one of those. I remember hearing about that paper at the British Endo Society meeting that was down in London, and it was definitely one of those papers that just blew my mind away. You know, just thinking, wow, they're doing vital pulp therapy, or effectively what was like a pulpotomy on teeth, which did have, albeit early lesions, maybe.
Yeah.
And they were getting better.
Yeah.
Which was just.
Which is just like
bonkers.
Totally not what we were taught, right?
Yeah.
And Taha also, in some of her studies, she used Dical. calcium hydroxide, right? And I'm just thinking, okay, but for that, I would like to move away. I think for you guys as well, probably knowing that there are better materials out there, and I understand why she did, obviously include that group in, right? But I think we have much better materials that we can rely on that are much easier to handle as well. I think if I did see a frank lesion, a periapical lesion, I think I have to put my hand up and say I probably will not go for sort of a pulpotomy in that case. I might want it, limited to sort of irreversible pulpitis, no periapical changes. I don't know how you guys feel about that. Yeah.
Definitely. I think, hands up, with a patient, in the practice, it's a different animal, isn't it? I mean, I think where it could come into its own, though, is, particularly for the generalists, if somebody comes in with pain, then they are going to pay for that appointment, aren't they? And, say they open it up and dress it, whatever, Ledamix, calcium hydroxide. They're only doing a pulpotomy ultimately, aren't they, to a degree, or a direct pulp cap.
Actually, you're right.
So you're just doing that, but rather than putting whatever you want, Ledamix or calcium hydroxide on, you're putting bioceramic on. So I think for the generalist with the pain patient, I think it's a slightly easier sell, isn't it? Because it depends on the time factor of it, but ultimately, this is
maybe an emergency session might be difficult to get all the steps right. But if someone has enough time, given the correct, sufficient time, aseptic technique comes in, and then you could probably actually do a decent job of some form of pulpotomy or like a
So. But so I think there's possibly. I think where they fall on their feet is they're just not using rubber dam, for it. And I think and I think that's where it falls down instantly. Then I still can't get my head around the argument. I haven't got time to put rubber dam on. Do you know what I mean? I just don't buy it. Having worked in practice for a reasonable amount of time, I don't like an argument.
I think with that, some of it is those emergency sessions, isn't it? It's what time they've allocated in the day. And if you get someone in as an emergency session and it's 15 minutes for an emergency appointment, say, so by the time you've done all your special tests and taken a history and done it properly, you're 15 minutes as well gone, hasn't it, really? Having that conversation with the patient and consent and all that sort of stuff. So I kind of, don't get me wrong, I still think the rubber dam issue is there, but it's a time thing then, isn't it? Because then what you don't want to do is they're one of those treatments that I think they'll work well by doing it there and then, won't they?
And I think, for the NHS guys, it's out, isn't it? You're going to struggle, to do it. But I think, in a private practice, but then, like we have an hour set aside each day, and some days I have nobody, and sometimes I can have quite a few, and sometimes I'll have one patient for the entire hour. So I could, you could kind of get on with it then, couldn't you? So, but
it's nice that you have that you do that. You actually set aside the time for the emergency patients. I think that's quite a good way to practice, to have that, so people can come in. I don't like the idea of people waiting in pain. So, but like you said, again, if you didn't have enough time. But I suppose in your hands, you probably could then do a vital pulp therapy as such within you could argue that's you could use that time, I suppose, I don't know, to get some sort of pulpotomy.
Even if, you kind of just septed on stream of, filling the entire cavity up with biodentine, if you've got your, I say it's very much time dependent, but I suppose if I have somebody or somebody has me with an emergency appointment, you could almost justify that as your fee, isn't it? I mean, your way is fantastic, and it comes back to the whole issue with dentistry, isn't it? You've got two heads. You've got your business head and your healthcare head, and this is where dentistry is such an enigma at times, isn't it? Because if you had, if you sat in front of the dragons at Dragon's Den and you told them that your strategy for managing pulpotomies, they'd go, what? Do you know what I mean? No, why? I'm not taking the risk for it. Blah 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 blah. Put your healthcare hat on and you want to do the right thing by the patient. You don't want to be overcharging them, etc. So it's just that massive balance, isn't it? And I think most people would sit in your camp, wouldn't they? But if you asked you asked Alan Sugar, you're going to get a very different answer, aren't you?
I suppose also it depends on, I guess it's for us also to kind of maybe accept the success rates as well. If you were convinced of the success rates, if and again, I look at, and also, okay, what was our biggest fear? We were talking about pain, right? Patients coming back in pain. Have you noticed a trend or a pattern as to when? So for me, again, in the limited number of cases I've done, it's within the 1 to 2 weeks I find that they should come back. If they've gone past that frame of time, I feel like, oh, okay, I think they're okay now. So I'll see them at this, maybe a 6-month review, for instance. So if they do come back within that period of time. And, and again, Neha Patel's work shows that their post-op pain actually was similar at 7 days post full pulpotomy versus root canal treatment, which for me, again, was also, so that was news to me as well. Like, that was surprising, because I always, in my mind, I don't know, maybe it's a mental block that I always thought, oh, they'd have more pain with some sort of vital pulp therapy treatment. So I guess it's a bit of a shift that we need to make ourselves as well, right? It's just, but again, reading a paper and obviously doing something in practice is totally two different things, and in private practice as well. I think if it's at NHS, would vital pulp therapy be considered band 2 treatment?
I asked, because obviously we were chatting about that last weekend, weren't we? And I put it onto the Facebook forum, because I'm working NHS for a very, very long time, and a couple of people came back, didn't they? And a premolar would be band 2, and a molar would come under band 3.
Oh, really?
Now, we don't actually know what band 2 and band 3 translate to.
I know band 2 is 75 pounds. 75 pounds for band 2. Am I right? That could be. We can double check. Because root canal treatment comes under band 2.
But does it depend on which tooth it is, though? Now, we have an NHS contract at the practice for kids, but I don't know anything about it really. I just have the pleasure of filling in all the useless paperwork and telling them when we're on holiday and things like that. But I don't actually know. I think they changed it, didn't they? It was band 2 for an NHS molar and whatever, but they changed it, didn't they? Add other supplemental bands. Yeah. We'll have people pestering us now, won't we? Telling us what they all are.
But you can find out and let me know as well.
But then everything gets crowned anyway, doesn't it? Well, not with vital pulp therapy, but everything gets crowned with endo anyway. So that was band 3 or 12 UDAs.
But it always blows my mind, when we have delegates in who are doing molar endo on the NHS, and they're buying their own files because they want to do the right job. And you just cry for these guys. Do you know what I mean? They are
bless them, saving all these molars. Band 2 barely covers your costs, right? But I wonder if it does cover your costs for vital pulp therapy, because if you're using biodentine, I think a capsule of biodentine works out to 13 to 15 pounds. Is that per? Maybe somewhere around there? I don't know if it's putty. So, and I'm just thinking, but time as well, isn't it? Because biodentine takes 12 minutes to set. So you're going to wait for it to set as well. Then before that, the criteria for us to whether choose to continue with the pulpotomy or not is bleeding time as well, right? Then you've got all this controversy of how long do you sit and wait and twiddle your thumbs waiting for that bleeding to stop. I think the guideline is 5 minutes, but I think I've been known to wait longer, because I'm just like not giving up hope, And
if it is still bleeding, might you be tempted to take a little bit more away and then wait again?
I think that's what we do, right? That's what we're told to do. I mean, of course, then I think then it goes into the burr that you use to obviously do caries free is one thing. That's probably the thing we didn't actually discuss, whether you do complete caries removal or stepwise.
I was going to ask actually. I was wondering what camp you sat in with that.
I'm going to be controversial and say I remove all caries. I don't know how you guys
do too.
I 100%.
That's the American way.
Yeah. Okay, so at least we're not arguing there, because I know there's evidence for obviously stepwise and but do you not think that because we're working under microscope, it just looks terrible to leave it behind, So I do tend to I remove. I like a clean start, and then switching burrs for the actual pulpotomy. And yes, if we're meant to, just remove just a little bit more. I have to say I've been guilty of getting to orifice and slightly below orifice before I actually got the hemostasis. And I think it's also a balance, isn't it? Because I had one case where I had done the pulpotomy, and then it kind of looked, what was left of it was looking rather pale. I was like, this is not good, because you need to have some color to that tissue to show that it was alive, right? And that one didn't work for me. Patient came back, clockwork, 2 weeks. Everything was good first week. I was like, oh, it's good. Second week, he calls. Obviously, it's a weekend. He's in pain. I'm like, oh my God, I don't want you to go in A&E. Go to A&E. You're going to wait around for how many hours for them to give you antibiotics? So we I reassured him with, painkillers, Monday morning, he was, in the practice. But that was the one case where I thought, do you know what? It looked, I knew something was not right, because it looked too, after I'd removed, just the sort of that coronal pulp, it looked rather pale. So it's kind of like...
The one question I always get asked is, how much do you take away? And I kind of go, well... I just take some away. Do you know what I mean? And then I take a bit more, and depends how much time I've got. How big a chunk I will go. If I've got an hour for that patient, I will probably nibble away. And if I've got less time,
and wait,
I might take bigger chunks. And it's like, when I've heard of people waiting up to 55 minutes.
That's a bit much. Really?
And you're like, well, that's not going to necessarily work, is it?
No.
In a practice setting, a hospital.
Really?
I think it's just such a mind shift change, isn't it? As I think we are the biggest barriers at the moment, aren't we?
Yeah, agreed.
Agreed. And I think it was interesting what you're saying about this 2-week thing. I've been surprised how little pain patients have had. Especially like you say, you do these things, they end up getting booked in on a Friday, don't you? And you sort of think, waiting for a phone call over the weekend, and nothing comes. And I might see the patient a week or so later just to check on them, and they've had no pain at all. And then I convince myself it's all dead. That's why they've got no pain, And
see, then you're worried on the other side as well. And I kind of see the benefits of a partial pulpotomy there. Because if you've done a partial pulpotomy, you've got your good old endofrost, you bring it out, and with some luck, you will get a response, right? But if you've gone and done a full pulpotomy, that's not going to be one of your sort of gauges for success, right? That's not going to be part of your assessment, I suppose. Then you're relying totally on, I suppose, clinical symptoms and radiographic sort of health in that sense, right? So, but you know what? There's also so much evidence for full pulpotomy. So I guess if in doubt, if it's still bleeding, nothing's stopping us getting to orifice level, right? And maybe not so much below orifice level, but doing a full pulpotomy, we know there's good success rates for that. So if it needs to be done, it needs to be done. But I'm always hesitant, I'm like, I'm removing a little bit, I'm watching, I'm removing a little bit more. I've got my sodium hypochlorite on that, sterile cotton pellet sticking on that, I guess the more we do, the more we'll start to feel more comfortable.
Do you think, I know there's been talk about it, but then do you think we need to change the terminology then from irreversible pulpitis? I know there was this push a little while ago for mild pulpitis and moderate pulpitis. And,
So that was the Walter paper, was it? With the new terminology. I mean, again, I think even our diagnostic terminology for sort of endodontic problems in general. I've been using AAE for many years. Then the BES came up with the good endodontic practice. So then I've gone to that, which is also similar to the AAE. But, before that, we had such variety, chronic apical periodontitis. Now we're going for symptomatic apical periodontitis, things like that, right? I mean, I think we really should agree on some standard terminology, and hopefully the diagnostic terms also relate to histology, right? Which we know is actually quite difficult to relate as well. But and maybe less categories would be nice. Because again, I think sometimes when you've got too many classifications and you make things too complicated, it puts people off. wanting to use it.
We do love classifications in dentistry.
Oh, endodontists love it, don't we? Yeah. But we're not as bad as the perio, though. I think we're still better than perio.
Oh, good Lord.
I have an app on my phone for the perio one. I have an app that tells me, you sort of put in what it is and it tells me what it is. But there was somebody who presented a case the other day at Simply Endo, and he's a really good dentist. He was actually really good guy. And he presents a really nice case, and he quoted some guidance on wear. It was, I can't remember what it was. It was a bit like a BPE, but for wear, which I'd never come across.
Is that
I'd never come across that. I was so every school day, I'd never come across it.
Well, he's just till his MSc.
Right. Yeah, I told yeah. But you feel stupid now because you're both familiar with it.
I'd like to just get credit for doing a BPE. Can I just say that? And then, move on from there, get the endo. I mean, we do a ton of tests ourselves, and we need to, there's so much already to write in terms of the notes. So, yeah, and nowadays as well, when you got the CBCT, and I don't know how much CBCT, I mean, you know how many you take for cases, but I'm definitely doing more and more, which means I've got the benefit of some extra, at least 15 to 20 minutes writing a report as well on my small field of view. So it's just, there's just so much for us to do at the end,
Do you think that kind of leads into AI? Do you think that AI is going to have a good place going forward? Because people have AI to do scans and all sorts now, aren't they? Yeah.
I mean, I think I've had, sort of heard people say different things about it. Not everyone's a big fan. But have you used DiagnoCat? Have you had to play with DiagnoCat for CBCT? Because currently that's the only one I know on the market that does CBCT reports. All the other ones are based on 2D radiographs. So we're doing a bit of research on that now to see how exactly your question, how well it reports, and also how it maybe agrees with what we would produce as a report, and also as I suppose a reference standard dental radiologist report. But I think it's helpful. It's always good. I don't think we should, as with all things, we're not relying on it 100%. But it's just to alert us to, but I found it a little bit like intimidating as well, because it does actually point out to you, like, short root fillings. It's quite critical. So it was your case that you CBCT'd, in some ways I feel like, I don't need to know too much, because it highlights everything pretty much. Yeah.
We don't want post-op CBCT, that's for sure.
Yeah.
It's like taking bite wings after you've done cons, isn't it? You don't want to see all the caries you've done.
No, you want that pre-op. Pre-op's fine. Yeah. So.
Yeah. Well, somebody again had brought in some AI software into Simply Endo the other week, and they were showing us it with bite wings and things, and it was pointing out stuff you almost probably didn't want it to, unless you were quiet in work and you wanted to do a bit more work. It was pointing out stuff that you possibly didn't want to see, possibly stuff that you maybe think, I'll keep an eye on that. But if it flagged it up in front of the patient,
I think probably is a problem, right? If it's pointing out too many, like every single shadow, I think, especially for 2D, it's quite tricky. And then you have the responsibility after that to decide what are you now that it's been pointed out. You have to decide what you're going to do, right? But I guess that was also a problem with CBCT, wasn't it? Because of the sensitivity. But at the same time, we also know with CBCT, you can get some false positives. If you're seeing maybe a millimeter, 1.5 millimeters of what looks like a sort of a widening of that PDL space, or what looks like it could be a very small periapical lesion, is that really a lesion? I think, and that's, again, I suppose that's where we remind ourselves that it's never just one finding, isn't it? It's bringing the whole jigsaw puzzle together and just making sure, because, we do see too much, don't we, with CBCT as well. So now with the AI, it's going to be much more. So
waiting for it to do the endo for me now, and I can sit back and just watch.
I think that'll be where we're safe. Do you not think? I think with all the robotic surgeries, this and that, I doubt it'll come to a point where the endo, it's too fiddly, isn't it?
I think it'll come. There's no
not in our lifetimes.
No, absolutely not. More so the patient acceptance of it. If you think about 2 or 3 generations time, if all they've known is robotics, doing it, it won't be a big thing. If I walked into a surgery and was doing it, I'd freak out. It'd be like a taxi turning up without a driver at some point.
That's the thing now, though, isn't it?
Yeah, whereas I think, for us who've not used to it, pilotless planes also, it does. I think it will come. And I was speaking to a guy actually who's been looking into this, and they say, the technique side of things isn't so much of a worry. It's more the diagnosis. And once the AI, the robot, whatever, can crack diagnosis, I think that's when it is. But at the moment, because, as we all know, patients, trying to get the right history, trying to match it all up, it can be tricky at times, can't it? It is a skill. And obviously that's what it can't, we have to look at we'll be able to look at the patient and we can say, is this really what's happening? Or, people undersell it, they oversell the problem. And that's where AI is falling down massively, which is great. 5 or 10 years till we're
still got jobs.
Yeah, maybe the other thing is the augmented reality bit, isn't it? The putting glasses on so you can see what your instruments are doing inside the root canal or something like that would be a good one.
I saw that. Was that Zoomax who had the goggles and you could? Yeah, I don't know.
I thought I'd just come up with that then, Shalini. I thought I'd just come up with that as an idea. No, have you seen it already?
You might want to. I think that it's happening. It's already happening. And then they overlay. So they overlay I think they can overlay a CBCT scan, like an axial view, so that you know where the canal is. I don't know, again, how accurate that is. With endo, it's about, like, sometimes it's less than a millimeter, obviously, tens of millimeters sometimes in terms of where we're looking for things, right? So I think for implantology, it was much easier to do the whole things like placements. I'm not sure how well it translates to us for sort of intricate endos. And even those the studies we've seen with guided endodontics, it's always been sort of central incisors. I mean, as far as I've seen anyway, maybe technology has moved along, but you're not. Is that going to find us an MB2? I don't know. It would be great if it did.
Just make your own, just drill your own MB2. That's the trick, isn't it? If you drill far enough, you'll make your own canal. And that's what they're doing, aren't they, really?
And then if it's not the right one, quickly patch it up with some biodentine. It'll look like nothing was there. Yeah, nothing to see here. So, yeah.
What would be your top tips then, Shalini, for someone who's just starting out on maybe on a course at UCLAN or simply endo, the sort of the MSc type program? What would be your kind of words of wisdom that you'd give people? I'm putting you on the spot a bit there, aren't I?
I guess I think I find, and I don't know if you guys find the same things. I think the students who get the most out of it are the ones who start the course but already have support in terms of like the practice principles, or they themselves are investing in the kit, and it means also getting the microscope. And hopefully it's more affordable now for everybody. But those who start off that way, because when we start, and I'm sure for you guys as well, they use the microscope on day one. And that's quite a big learning curve if you're on a part-time course and you're just coming. Because I've had students who only use it when they come to the course and they're not actually using it in practice. So I think things like that, and if they invested in proper sort of the endomotors, like you say, some of them, bless them, NHS buying their own rotary files, trying to just up their game, trying to make sure they're efficient and also doing a good job with the endo. I think like your course, we introduced them to CBCT as well very early on, just making sure that, if you also have that practice in, where you're working, incorporating all those new things that you've learned perhaps, earlier on. I think you'll get much more from the course. And I know it's not everyone who can do that, but I feel like they'd get the most, because then it's in parallels, and it's quite tricky, isn't it? Because it's a part-time MSc. You guys are running a part-time MSc as well, so you're seeing them. I see my students maybe twice a month in those cases. So just making sure that they're having that practice as they go along to make sure that there's that those skills are developed in time for us, especially before we get into clinics. So at the end of year 1, we have the clinical session starting, and of course the whole of year 2. So just to make sure that they are, because again, also it feels like I'm dropping them in the deep end as well, because I don't know if you're aware, but here, I guess you guys based in Liverpool, you can have some referrals, general dentists can refer to Liverpool. Here, people do try Liverpool, Manchester, we get rejected a lot.
Yeah.
So they come to, patients get to UCLAN, and I don't necessarily always get to choose like relatively simpler cases for them. Sometimes they're starting off really, what you would get in practice, what you'd be referred in practice, the complex ones. So I guess it's building up to that. That wasn't really a very short nutshell type of thing. Sorry.
It was great, yeah. But, yeah. Great answer, isn't it? Yeah, yeah. That is hard, isn't it, when they turn up and they're just using hand files?
Yeah.
And they don't have the support. It's nice then when you see them progress with stuff, but it's a slower turning ship, isn't it, than if they're ready to rock straight away. Yeah. Definitely.
So, yeah.
Fantastic. Any more to add, Rob?
No, just to thank you very much.
Oh, yeah, we've taken up a lot of your night there, Shalini.
I've really enjoyed it, thank you.
And, I've had the pleasure, Shalini, of listening to you speak when you spoke with Mike at the Piers thing we did at Simply Endo. And,
that was still my favorite and most fun CPD night. Was that not like it? I laughed so much with you guys, and I said to Mike, every CPD event you guys need to be in the front row, otherwise it's not the same. It was good, yeah. And we discussed some controversial issues as well, complications. I guess the topic as well was quite nice to share, wasn't it? So yeah. Thank you for inviting me back for this. It's been and thank you for making it so the conversation flowed, because it's like talking to friends, isn't it? So I appreciate that. The nerves went.
Well, the people at UCLAN are lucky to have you, aren't they? Because we didn't have undergrads and people like yourself. So your enthusiasm and interest in endo is just fantastic.
Yeah, very much.
I've enjoyed it really, really much.
No, thank you very much.
Thank you.